I'm going to talk about headaches because I see patients from every state of the union, and the one thing they all have is headaches, and I'm always trying to differentiate one process from another. And so I'm going to share that experience with you. Can you? So we're going to discuss most of these things, and this is the differential and more that I consider with almost every patient that I see. So Chiari malformations, this is the CSF meeting, so the Chiari headache is usually one of precipitated by cough, a Valsalva maneuver, and maybe brisk, fleeting, or last hours or even days, and often accompanied with signs of brainstem or cerebellar dysfunction. And we treat it with a suboccipital decompression with or without a dural patch. But here's a patient who underwent a decompression 10 years before, and she did very well. She was running a large medical practice and then came into the emergency room with increasing headaches and memory loss and fatigue. And this was the MRI. And I thought, oh my goodness, this patient is re-herniated or not isn't decompressed enough. Do they need, and there seems to be some ventral brainstem compression. We obtained a CT scan, and the CT showed what looked like a decrease in subarachnoid space. And we obtained an MRI, and we saw increased swelling around the pituitary gland and increased blood flow down the spine, and then looked at the sinuses and saw that she had a thrombosis of the transfer of the left transverse sinus. She was treated with, here's the other MRI showing no flow through the left transverse sinus. She was treated with Lovenox and made an excellent recovery, did not need any surgery. And there she is sometime later showing restoration of flow. Now this young lady from Canada came in with a global headache which had been rapidly increasing over a few days. And she also had severe leg weakness and urinary incontinence. And I thought, well, you know, is this a tethered cord or what's going on? And then she developed memory loss and personality change. So we obtained this MRV, and you can see the loss of flow through the right transverse sinus. And she went from coma to back to normal within several days. So this begs the question, how does blood leave the brain? And actually, Hal has done a lot of work with this and done a lot of thinking about it, but in the upright posture, there's increased flow through the vertebral venous plexus, and lying down, there's more flow through the jugular veins. And so here's a normal jugular vein on the left, and on the right you can see there's compression of the jugular vein by the transverse process of C1, often under the belly of the posterior digastric or the stylohyoid ligament. How often does this happen? In larger series of CT angiograms, and I imagine that only people with problems undergo these CT angiograms, they don't do them on normal people, but 1/3 of CTAs show jugular venous compression, 18% show severe stenosis, as you see on the upper right, and 9% have increased collateral flows, like this one below, one of my patients showing anterior and posterior lateral condylar veins. And this another patient had a bilateral obstruction of the internal jugular veins, and you can see this massive collateral flow through the vertebral plexus. So raised intracranial venous pressure may underlie many cases of intracranial hypertension or pseudotumor cerebri. So pseudotumor usually arises in the 3rd and 4th decades, women more than men, presents as headache, visual changes, retroorbital pain, pulse synchronous tinnitus, and if you do a lumbar puncture, you might see a CSF pressure greater than 20 in a normal person, or 25 centimeters for an obese patient. with normal CSF composition. And we know there are many treatments for intracranial hypertension, most commonly ventricular peritoneal or lumboperitoneal shunts. Some people are doing optic nerve fenestrations for visual changes. But now there's some folks like Kenneth Liu and Dr. Higgins at Cambridge in England and Sunil Patel's group in Charleston that are doing more stenting for increased venous pressure. So there's a transverse sinus stent on the left, a jugular venous stent on the right. Now, what about the other side? What about intracranial hypotension? Because many of the patients who are developing pseudotumor have connective tissue disorders, and they have thin dura, and there's a proclivity perhaps to developing intracranial or a spinal fluid leak with intracranial hypotension. These patients have an orthostatic headache, nausea, vomiting, anorexia, neck pain, dizziness. Sometimes they have horizontal diplopia, changes in hearing, galactorrhea. They may even have orthostatic facial or ridiculous sensory motor changes. It's exacerbated by laughing, coughing, jugular venous compression. Now, if you do a lumbar puncture, the pressures will be less than 6, but Mark Luciano's group has done really excellent work on this, and they've found that if you want to make a diagnosis of intracranial hypertension, you should put in an intracranial bolt and then sit the patient up, and those intracranial pressures should drop to less than 7 centimeters H2O. Mark, is that accurate?
Well, actually, we're using 9 or 10 at this point.
9 or 10. So intracranial bolt for diagnosis. And here's some MRI findings. There's a venous engorgement around the pituitary gland. We see a thickening of the pachymeninges. There's loss of the prepontine space and other cisterns, and sometimes also a descent of the, sorry, one of those arrows is wrong, descent of the cerebellar tonsils. And in the spine, once in a while, you might see epidural fluid, and you might see engorged veins like this one on the axial view, reflecting increased venous flow in the epidural space. What about arterial headaches? Miles Kobe discussed one case of a patient with EDS who developed extraordinarily high pressures, and we do have some patients with hyperadrenergic partial orthostatic tachycardia, where when they stand up, the adrenaline response is so strong that it drives the pressure very high, and these patients need high doses of clonidine. At any rate, this is a patient with a vascular type EDS, and she came in blind ophthalmoplegic on the one side with a 9mm proptosis, normal on the other, and this is a carotid cavernous angioma. Here's a patient relatively asymptomatic, who had a right vertebral artery dissection. The dissections usually occur after physical trauma, blunt injury, manipulation, and they're more common in the hypermobile spectrum disorders. They usually have a suboccipital headache, altered vision, sometimes dysarthria, impaired coordination, or stroke-like symptoms. Here's a patient from Canada. She had transient ischemic attacks, headache, and she had this anomalous supply of the left internal flow coming across from the right carotid and through an anomalous vessel through the pituitary fossa. Very, very odd. This young lady with known EDS came to the emergency room with the most severe headache of her life. We thought it might be a subarachnoid hemorrhage. The CT scan was normal. So we obtained a CTA, and we found a dissection of the carotid on the left, and then we found it again on the right. And remarkably, her only deficit was a very small infarct with almost no neurological changes. So back to the Chiari malformation with headaches. here's a patient with a good Chiari and a syrinx. So is that headache due to the Chiari malformation? In many series with good follow-up, we see a 20 to 50% failure rate following suboccipital decompression. The symptoms come back. So in some of these cases, at least, ligamentous laxity may be one of the reasons for failure of the Chiari decompression. In CLECAMP's series of 45 revision surgeries for Chiari 1 malformation, 10 had to undergo craniospinal fusion because of untreated basal invagination or craniocervical instability. And he stressed that if functional studies in flexion extension demonstrate hypermobility of the craniocervical junction, then decompression should be combined with the appropriate fusion. Miller showed that 13% of Chiari patients had a hypermobility connective tissue disorder, but it's important to remember, as Roger pointed out yesterday, that many of these EDS patients have Chiari-like symptoms, but they don't have a Chiari. They have craniocervical instability and other problems. And it's not surprising that if you have a connective tissue disorder, that you're going to have problems at the craniocervical junction, because ligaments are the structures that stabilize the craniocervical junction. If you have loose ligaments, you'll have a loose craniocervical junction. Now, Gould said that that a small amount of instability can cause microtrauma to the nervous system, and this can decrease neuromuscular control of the neck and gradually increase and result in progressive instability. And this problem is made worse with malnutrition, vitamin deficiencies, and deconditioning. And Dr. Kula made the point this morning that as a population, we're becoming more deconditioned. And in the hypermobility connective tissue disorder population, more than 50% of those patients have vitamin deficiencies. So for the last 20 years, many authors have noted the predominance of developmental coordination disorder, headaches, quadriparesis, clumsiness, and they suggested that there was CNS involvement in EDS. Van der Pep and Malfay published this case of ventral brainstem compression. She doesn't have basal invagination by the traditional criteria, but you can clearly see that there's a major deformity of the brainstem. And Doug Brockmeyer, in his series of 101 patients, noted that almost 20% needed an occipital cervical fusion, and the risk factors were a kyphotic clivoaxial angle of less than 125 degrees or basal invagination or the presence of a Chiari 1.5. So when does ligamentous laxity at the craniocervical junction become pathological? About 5 years ago at this meeting, we had in San Francisco, we had members from 17 institutions come together, and we achieved a consensus that there were 3 additional metrics, most of which have been discussed this morning or yesterday, that are helpful in looking at the Chiari population. The clivoaxial angle, the Grabb Oakes Measurement, or the PBC2, and the Harris measurement, also known as the Bayesian axis interval. So here's the clivoaxial angle between the clivus and the axis. Normally it's greater than 150 degrees. And if it's less than 135 degrees, it's considered potentially pathological. And you can see this angle is about 100 degrees. That is very pathological, and there's a significant medullary kink there. The Grabb and Oakes published a paper in 1999, and they described the Bayesian to posterior inferior C2 line. And a measurement from the dura to that line of greater than 9 millimeters is considered high risk for ventral brainstem compression. And Harris looked at 400 normals, and he found that none of the normal patients had a Bayesian to odontoid distance greater than 12 millimeters or more. So the Harris measurement from the basion to the odontoid is a good measure for craniocervical instability. So in flexion extension, many authors have shown that the basion pivots over the mid-odontoid, and there's no translational movement. So that's normal. And these people have discussed that. Now in this case, on flexion, you can see that the basion is lying about 6 millimeters anterior, and upon extension, the basion slides backward. So there's a 6 millimeter translation. That's pathological. That's craniocervical instability. And this patient, you can see a Harris measurement, a basion axis interval, 15 millimeters. That's, of course, unstable. Now, it's very important to get dynamic images. On the view on the left, that's a relatively normal-looking brainstem and spinal cord. But if you obtain a flexion view, then suddenly you can see that there's significant basal invagination. You wouldn't have seen that without dynamic imaging. So we're all familiar with the symptoms of craniocervical instability, so I'll move on, and the treatment, craniospinal fusion stabilization. And typically with that surgery, we see an improvement of headache. We're about to hopefully publish a paper with 5-year follow-up on 20 patients I did 6 years ago. And we saw an improvement of headache from 8 to 4. The headache did not go away because there are always many causes for headache. But the patients were substantially improved. Now, there are some genetic diseases like this HOXD3 homeotic transformation, where there's a gene deletion resulting in a disordered body plan, and there may be a segmentation failure between skull and C1, leading to instability at C1-2. And this patient of mine with Ehlers-Danlos syndrome and 2 sisters who had also had surgery by me was a French horn player. He was unable to blow his horn anymore. And he had a HOXD3. But I performed a Chiari decompression on him. And a year later, he's doing great, playing his French horn. And he, much to my surprise, did not need a craniocervical fusion. So the radiological metrics, I said, are useful guidelines. They're certainly not rules. And I don't do a fusion on anyone unless they have intractable and disabling pain, congruent neurologic deficits, and radiological findings. So Dr. Long mentioned earlier, and in other papers, that many headaches are cervicogenic. And in 2006, he noted that of the many patients at Hopkins who had undergone a Chiari decompression, 25% continued to have headaches, and most of these were cervicogenic. So in a large series of headaches, they found that 2/3 of the population have headaches at some point. More than half are misdiagnosed. But the ones with the highest quality of life burden are the cervicogenic headaches. So here's a C1-2 instability. And in Halco, a series of patients with vascular EDS, 25% had this C1-2 subluxation. But other authors, Nagashima, Menezes, have also written about atlantoaxial instability. This is some excellent work by Francis Smith over in England, and you can see on the left the transverse odontoid ligament. It's a black band lying just posterior to the odontoid, and next to it in red is a high-grade lesion, and there's a loss of that ligament. And that results on the far right in atlantoaxial instability, and that's the type of instability that we all learned in residency, typical of rheumatoid arthritis and trauma, but it's not the kind of lesion we typically see in the population with hypermobility connective tissue disorders. In that population, we see alar ligament incompetence. And in the normal population, rotation between C1 and C2 on neck turning varies between 23 and 39 degrees. And it's limited by the transverse capsular and the contralateral alar ligament. Harold Hoffman recognized after the work of Dvorak and Punjabi that overstretching or rupture of the alar ligaments results in rotary hypermobility or instability. So this is Francis Smith's work. On the left, you see a normal alar ligament. It runs from the foramen magnum down to the anterolateral aspect of the odontoid. And on the right, there's a high-grade lesion of the ligament. So how do we diagnose atlantoaxial instability? These patients come in with severe suboccipital headache, very often in the distribution of an occipital neuralgia. They may have ice-pick eyes. It's worse with looking up or down, really bad driving over a bumpy road. So coming into DC is a great diagnostic feature for my patients. Syncope is another common feature. Many of these patients have syncope or presyncopal episodes, and they often have total body pain, like their skin hurts everywhere over their body. And finally, most of these patients have significant visual changes, anything from tachopsia to blurred vision to tunnel vision. And we diagnose them by allowing them supine on a CT scanner and asking them to turn their head to the right and left, and then measuring the angle between the C1 and C2. And on that upper right, you see a 45-degree angulation, and that's pathological. So Menezes said that at a 40-degree rotation, the vertebral artery is stretched and kinked, and at 45 degrees, there's occlusion of both vertebral arteries. Sometimes we see other incomplete rings and so on. If you see an axial view like this with an eccentric odontoid, then you should be suspicious for an incompetent alar ligament. And Goel has described atlantoaxial insufficiency with normal atlantodental intervals, and he finds intraoperatively that there's a vertical instability between C1 and C2. Interestingly, though, the case he pointed out seems to have a HOX-D3 homeotic transformations. Ian and you also showed other types with retroversion of the facet causing a posterior olesty. And the treatment is simply fusion and stabilization. Now, the Kimberley anomaly is very common. It's just the calcified ring over the vertebral artery. Occurs in 14% of the population, but once in a while it can cause deafness, dizziness, drop attacks, even arterial dissection. It's the real pitfall in looking at the head to not look lower down on the spine. And this patient on the left looked quite normal. On the right, a dynamic extension view shows stenosis and cord compression. So cervicogenic headache is due to cervical instability. And in some of these, this is a young woman who had impaired visual accommodation, mild deltoid weakness, hypoesthesia of the shoulders, a headache severe enough that I thought she might have a pseudotumor, but her MRI looked quite normal. And when I obtained a dynamic flexion MRI, I saw this cord compression and a simple ACD, and her symptoms went away, and she went home. Benzel and Shadid published this case in 2007, showing on the left a relatively normal-looking MRI. On the right, you can see a severe kyphosis, a stretching of the cord with a bowstring effect, causing a significant myelopathy. Again, this only came out with dynamic imaging. Punjabi and White have elucidated the test for clinical instability, and the key thing is if you see an angulation at one level of 11 degrees or more, be suspicious for instability. Now, you may have a normal neurologic exam, but neurogenic pain. So with peripheral nerve sensitization, such as with occipital neuralgia or lesser occipital neuralgia or third occipital neuralgia, you can have normal neurologic exam and disabling pain. But this will be diagnosed by neurologic exam, or by a good history and a nerve block. So the occipital neuralgia can be very severe, last seconds, but usually it lasts hours or even the whole day. And it can be very disabling, and it's very easily treated. This patient came in with migraines, and with Ehlers-Danlos syndrome, the incidence of migraines is 3 times higher than the normal rate. But she also had TIA-like symptoms, and so I obtained this echocardiogram with bubble technique, and it showed bubbles through the patent foramen ovale, and we just treated her with aspirin. She did fine. Now on the left, that myxopapillary ependymoma could be expected to cause a headache, but on the right, this other patient with a very large myxopapillary ependymoma had a severe headache, and after I removed the tumor, the headache went away. So there's obviously some traction phenomena. And this patient with tethering at the T2 level posteriorly from trauma also had headache, and typically tethered cord syndrome causes a pulling sensation on the back of the head. This can be provoked by straight leg raising and other provocative traction signs. Tethered cord syndrome can be radiologically occult. This is a fatty phylum, and in one study, I think 80% of tethered cords had suboccipital headache. I won't go into the features of tethered cord. TMJ dysfunction is very common in the hypermobile population. TMJ is highly innervated, and surprisingly, it does not refer pain usually over the temporomandibular joint. TMJ dysfunction refers pain to the subocciput, the temporal region, and above the eyes. So it's often confused with tension headaches. It also causes muscle spasm in the trapezius and the levator scapulae. They can be very severe. It's usually improved somewhat with benzodiazepine, and they need to see a really good dentist to get that fixed. Disorders of immunity. We're seeing a lot more mast cell activation syndrome. Ann Maitland has given some fabulous lectures on this, but mast cell typically presents with headache, brain fog, fatigue, irritable bowel, cystitis, muscle aches, and it can be quite difficult to diagnose, and the best way to diagnose it is that constellation of symptoms. It's due to these primitive cells that result in inflammatory changes. They release about 50 cytokines and chemicals in response to environmental, bacterial, and viral stimuli, and they can cause inflammation all over the body. And the most characteristic finding is the flushing or anaphylaxis or pruritus that patients manifest. In this population, we see a higher incidence of the pediatric autoimmune neuropsychiatric disorders associated with streptococcus or pandas. That's in children, and it occurs in adults and results in behavioral changes, tic, and headaches. I've seen neuropichets, inflammatory encephalopathy, and we're also seeing more cases of the paraneoplastic limbic encephalopathy, which antibodies to various tumors, viruses, bacteria, which then turn and attack neural receptor components in the central nervous system. Emblematic of which is the anti-N-methyl-D-aspartate encephalitis, which is potentially lethal, usually in women, causes behavioral changes, seizures, and the PET scan will show this increased activity in the limbic system. So in conclusion, though a useful measure of disability and suffering, headaches are highly variable, non-specific. Because these diagnoses are not always obvious or intuitive, you have to consider them and look for them. And awareness of the many comorbid conditions of connective tissue disorders is important to establish the origin of the headache. Ligamentous laxity finally, is an important feature in many of the conditions that generate headaches. I'd like to acknowledge my co-workers and thank you for your attention.